Welcome. We're very excited today to have three special guests of the department presenting for Grand Rounds. As you know, our residency has a research year, and this is really a very unique portion of our residency program that I think helps attract the best and brightest residents and gives people an opportunity to explore scholarly activity during their residency. And so we reserve these coveted Grand Rounds times each year to hear from our chief residents, to hear about what they've done during the research year and to hopefully inspire other trainees to develop their own research programs, both during residency and specifically during the research year. So I will introduce each of you as you come up. So first we have Dr. Max Bowman. He's going to be talking about his research year, and we are very lucky to have Max staying on as faculty afterwards. So very excited to see Max's work. And I think one thing that I would say about Max's research year was, he had what you might call out of the box concepts about, what to do during research year. And he's an example of somebody who did it really well. He pursued a lot of quality improvement initiatives, and he did it in a way that he was able to study it, publish it, report on it, get awards for it. And so I think it's really, shows that there's a huge breadth of what you can do during research year. And Max is a great example of how to do something that might be a little bit different, but still make it really impactful. So welcome, Max.
All right, thanks, Dr. Hampson, for that introduction and spoilers. I'm Max. I don't know a few of you. Nice to see you guys. So I'm going to get started. My talk I called the very uninspiring lessons in quality improvement. I'm going to make it more interesting than it sounds, I promise. But really, as Dr. Hampson kind of said, it's just going to be sort of some reflections on my research year, some lessons I learned along the way, and just kind of telling you about my experience. So my research year areas of focus, I kind of broke it down into a few different domains that I was interested in. As Dr. Hampson mentioned, I wasn't really coming into it with a big interest in sort of what you would consider traditional research. And so these were the things I kind of identified that I was interested in. So quality improvement, education and research, wellness and burnout, leadership and healthcare delivery. And these are some examples of some of the projects I did under each of these domains. As you can see, it was a pretty busy year. It was incredibly gratifying, and I really learned a lot and had a lot of fun. So as Dr. Hampson alluded to, I think there were some concerns when I designed this research year that it was a little non-traditional. This actually is not a direct quote. I made this up for dramatic effect. But I'm pretty sure a lot of people were wondering in the back of their heads, like, what is there anything going to be delivered at the end of this year? And I was wondering that myself. And I just want to just take a quick moment to just point out that, yeah, I mean, like, people are pretty interested in hearing and learning about this stuff, and it is very publishable. So here are some of my publications from the year. As you can see, there's a variety of things that kind of came out of this year, and it was really a lot of fun. I feel like I grew a lot as a writer, as a researcher, kind of despite my best effort. So it was really a nice time. The next direct quote: do people actually care about this work? This was said by me. Like every single day, I had a lot of existential wonder as far as, does this matter? Like, do people actually like care about this type of thing? And I think, like, to my surprise and I think delight, I found that people do. In fact, I won a competition through the AUA for quality improvement and patient safety, along with Dr. Van Kijken. We did a project that I'll talk about a little bit later in the talk. And then here, I was also nominated for the GME Award for Excellence in Innovation by Dr. Hampson, Dr. Breyer, Dr. Carroll. And I ended up winning that for some of the work that I've been doing here. So I think it is pretty valuable. People do care about it. And my outdated headshot got spread around a lot. So, I care about QI, but my personal opinion is that everybody should care about QI. And I think these are some of the reasons why. Our system is terrible. I think everybody knows that. Like, to operate in our system is to know that it is very dysfunctional and very inefficient, and there are constantly ways that it can be improved. And this is really what got me interested in this in the first place, is just seeing the inefficiencies in our program, in our process of delivering healthcare and doing surgery and seeing patients in clinic, seeing how vulnerable some patients are to falling through the Swiss cheese, so to speak. And this type of work is an opportunity to change that if you just have a little bit of motivation and some time, which I had during a research year. QI has an immediate impact. Change essentially happens as quickly as you can implement a project. There's no waiting for an extended period. You can just kind of bring something to life and start changing things right away, which is really exciting. It improves the lives of many people on many different levels. This includes patients, yourself, your colleagues, the hospital, the health system, and beyond. And QI projects can happen really quickly. So really, there's no IRB that's needed. There's relatively little funding needs. And there's fewer barriers like enrollment or recruiting. And yeah, as you guys saw, I carried a number of projects from beginning to end in the matter of a few months, which was really exciting. And it's great to be able to kind of push things through so quickly. And finally, the QI umbrella is very broad. So really anything under the sun that needs to be changed is QI. And I think that's really exciting as well. If you see something, you can change something. So it's, whether you feel like your clinic is not running as efficiently as possible, you want to take advantage of more block time, you want to get paid more, you want to increase the safety of your patients, decrease complications. That's all under the umbrella of QI. And it's I think, a really exciting space to work in. So how do we get started? I want to tell a little story that I stole from a TED Talk by Ernesto Ciroli. Some people may have heard this. It's a pretty well-known TED Talk from many years ago. But Ernesto Ciroli is an Italian man who dedicated much of his life to aid in Africa. And he tells the story from when he was in his 20s and he went to Zambia to kind of bring agriculture to the people there. And they arrived in Zambia. They found this amazing fertile valley that hadn't been developed at all. And they thought this is great. They planted a bunch of tomatoes and zucchini and other crops in the valley. And they grew twice as big as they get in Italy. And they were very excited about it. And they said to the Zambian people, like, oh my God, like, isn't this great? Like, thank God we're here. We now brought you agriculture. And overnight, 200 hippos came out of the river and ate all the tomatoes and zucchini. And the Italians were like, oh my God, this is terrible. Like, I can't believe this happened. And the Zambian people were like, well, like if you had asked us, we could have told you that this is why we don't have agriculture in Zambia. And the title of his talk is, if you want to help somebody, shut up and listen. And I think this is a really powerful lesson in quality improvement and probably one of the biggest takeaways I had in doing some of this work. And I'll illustrate that a little bit more as I dig into one of my projects. So again, these are the things that I did during the year. I want to focus a little bit on one of my projects here, what I called the Rosetta Kidney Stone Project. To do this was with Dr. Van Kijken as my primary mentor. It was really a lot of fun, a big learning experience for me. It was through the Reflect program here, which is an annual quality improvement kind of initiative that's led by the health system for residents and fellows across all the disciplines. We started by identifying a problem, which is that in our urology clinic, we don't really have non-English discharge instructions that are standardized for patients that don't speak English. So we kind of set out to study this and to ultimately change it. So the intervention really started with understanding what barriers existed to providing these instructions and then implementing a system to deliver these instructions to our patients. The target we set for ourselves was to achieve greater than 60% of these patients with limited English proficiency going home with instructions in their native language after a procedure in our clinic. So to start, we identified multiple barriers that were standing in our way of achieving this project. And then through a lot of kind of the PDSA cycle and kind of studying and going back and reflecting and changing things, we ended up with several interventions to address each of these barriers. The first was, it was really unclear what needs actually existed. This is the shut up and listen part of this project. We started with surveying the clinic, the staff, the attendings, the nurses, seeing where the gaps were and where we could actually help and fill in. We also had I had a pretty limited understanding of the clinic workflow, and I spent a lot of time working with the staff there to really truly understand what things were like before I even started thinking about any solutions whatsoever, and just understanding what the system was from the moment a patient checks in at the front desk to when they're up in stirrups with Dr. Breyer to when they're going home. And then really, we didn't have standardized instructions, even in English. People, I think each of our attendings had their own instructions, but there wasn't anything that the clinic actually had with our official kind of approval that were handed out after these procedures. And so we created a library of English instructions. And then using the UCSF translation services, we were able to translate those into our most common languages, Spanish, written Chinese, Vietnamese, Russian, et cetera. And then we didn't have any space for the physical instructions in clinic. And so we set up some binders at the front desk and in the clinic rooms. And we trained the nurses and MAs to hand these out after the procedures that the patients underwent. And that plays into the workflows for delivering these non-English instructions. The intervention here also included monthly feedback sessions with the staff that I had kind of religiously during their morning huddle each month. And these were really critical times because there were a lot of things that didn't work very well at the beginning, and we had to change and adapt and kind of rearrange the way that we're thinking about things. Additionally, some really great ideas came from the MAs and the nurses, including creating an online version of these that patients could access with a link or a QR code, because they said, like, hey, these are great, but some patients don't want to leave with the paper in their hand. They want it on their computer. So it was a really valuable contribution. So our results, we set, as I said, a target of 60% of patients going home with these instructions. We implemented this after initial studying and everything in the first 2 months of the year, implemented in October, and we had a slow rise up to 60% by the new year. And then we were able to maintain that goal and exceed that goal in the latter half of the year. The overall average for the year was just over 60%. So we were able to achieve our target, which was really gratifying. We were able to help a lot of people. I learned a lot during this process. And I took these lessons forward in the other projects that I did throughout the year as well. So some of the lessons that I learned, a little more esoteric. I'm not going to go through QI tools, fishbone diagrams, Swiss cheese model, PDSA cycle. That'll be for the future when I'm faculty here teaching all the residents and forcing them to do QI. But some of the kind of broader lessons that I learned: start with problems, not solutions. I think that so often a solution is thought up by whoever is in charge, managers, whomever at the top, and that it's kind of forced down below, rather than actually starting with what is the problem as told by the people on the ground, the people doing the work. It can't be your own sense of what the problem is. It has to be, hey, the nurse in the clinic, what is the barrier that you're having here? What is the sticky point? How do we fix that? That leads into studying, listening, understanding, and really examining the existing structures before anything else. Like I said, you can't plant tomatoes in the Valley of the Hippos. You have to know the system that you're operating in to really effectively have a long-lasting project. It's really important to partner with the stakeholders on the front lines. These are the people that are there every day doing the work. They have to be invested. They have to have some ownership over the project, and they have to feel like there's some accountability there, or else it's probably not going to get off the ground. And then, like I said, the best ideas really come from the ground up. It's really important to be flexible and adaptable. Like I said, we kind of changed course several times throughout some of these projects. And I think ultimately, if you're so rigid in implementing a project, it's never really going to work. And really, failure, in my opinion, is the most valuable tool in QI. Integration within existing workflows is better than creating new ones. This is something that I observed for several of my projects. I think unless the system itself is what you're trying to change, people are used to doing things the way that they do them. They're very habituated. And if you work and integrate your intervention into their existing structure and infrastructure, it is a lot more effective than trying to tear it down and make them do things completely different. And then it's really important to evaluate progress constantly. And like I said before, don't be afraid to change course. Solutions to complex problems are rarely linear. And some final takeaways from the year. I had a wonderful time in my research year. It was a really valuable time for me. I grew a lot as an academician. I discovered a passion in academics that I didn't know I had. And it was really a career defining. I think I will be taking these things forward through the rest of my working life. And it really kind of set a course in my life that I didn't anticipate, and I'm very pleasantly surprised by. So along those lines, academics is pretty broadly defined. This is kind of addressing some of the residents in the room who might be kind of hesitant about academics, if there are any. You have to kind of think outside the box. It's not all about doing traditional research. It's not all about getting grants. That stuff is wonderful and super necessary, but there's a lot of other space to work here. And I think I found that and really tried to take full advantage of that and find your niche, whatever you're interested in. This is what Dr. Van Kijken says all the time, but research can be an opportunity, not a burden. Like, it's actually a privilege to be able to study something, understand something, and change things. And once you get higher and higher to the point where you are doing your own projects, I think that is more and more obvious. And then finally, my one of my biggest lessons is to lean on my mentors. I've had so many people in this room and outside of this room that have helped me throughout this process. And it's really important to be an active mentee. I feel like I learned a lot about how to do that during this last year. And honestly, this is the best part about being a UCSF urology resident, which I tell people all the time. I think that we're so lucky to have such amazing mentors here. Here are some of my research here mentors. There's so many other people that I couldn't fit on this slide, but thank you so much to all of these people here. It's just been like a wonderful time. So thanks for everybody. And I'll take questions if you need.
So we'll do questions at the end just to allow us to get through everyone. So next up is Dominique Escobar. Dominique had a really amazing opportunity. She got accepted to the UCSF Radiology T32 program, and that's a huge accomplishment for her. And we're really grateful to the radiology department for opening that opportunity up to us, because I think programs like the T32 allow people to get dedicated mentorship, training, grant writing experience. And these are really impressive programs that really are trying to develop people for future research. So if you see those opportunities, and there's many of them at UCSF, we're lucky to have a lot of them at this institution. We definitely want to take advantage of them when we can. And hopefully Dom will tell us a little bit about how that played into her research here. But Dominique's graduating and going on to USC for a fellowship in oncology, which has been her passion for as long as I can remember. And we're super excited to hear, Dom, about your research here. So thanks.
All right, thank you for the kind introduction. So before I get started, I can just talk a little bit about my experience in the Radiology T32 program, which was an awesome experience. I really love imaging, and radiology is one of my favorite parts about being a urologist. And so this opportunity to sort of blend my interest in imaging and in urology was really awesome. It also gave me the opportunity to take some coursework and to learn sort of basics of research that I truly didn't know before. I really came into all of this with really limited research experience. And I think, the experience that this program gave me was incredible in just understanding how to design projects. I did a lot of this analysis actually myself, which if you had told me a year ago I would be doing that, I would tell you that's absolutely not possible. And even though most of the analysis is fairly basic, I think to be able to actually use data independently, put code in, get results out, and present them has been a really amazing part of the program, and a huge takeaway that I took out from this. So it was an awesome program. So I'll start off with just a little bit of background of my project and then get into some of the details. But my project is basically looking at the SUV max on PSMA PET scans in initial staging for patients with prostate cancer, and trying to understand what the clinical utility of the SUV max value is. So just a little bit of background. This is probably not news to most people in the room, but maybe for some of the medical students or the more junior residents. So prostate cancer, as we know, is a really important problem that we take care of on a daily basis, and is a leading cause of death from cancer, both in the US and worldwide. And precision medicine, as we know, is becoming very important in the management of these patients, with advances in imaging and genomics allowing us to make individualized treatment plans for our patients. And PSMA PET, as well as we know, is a mainstay in prostate cancer across the clinical spectrum. So in the initial staging setting, in evaluating for recurrence and evaluating response to treatment, we are using PSMA very frequently now. And PSMA, for those who may not be familiar, is prostate-specific membrane antigen, which is a cell surface protein that's expressed by normal prostate cells, but appears to be overexpressed in prostate cancer cells, and thus has become an important target both in diagnostics and in therapeutics. And it's encoded by the FOLH1 gene, which will come into play shortly. And then a little bit of background in terms of Decipher. So this is one of the many genomic tests that we have available to sort of help us risk stratify patients and get a better understanding of their risk level. There are multiple levels to the Decipher. So there's the sort of raw Decipher score that probably all of us are most familiar with, which is a score from 0 to 1, gives you an idea of a patient's risk level in terms of low, intermediate, or high, in terms of adverse pathology or risk of metastases. And The next level up is signature scores. These are basically scores that are given to a measure of these biological pathways that are important in prostate cancer. And then there's the Decipher grid, which is a research-only aspect of Decipher, which is essentially the sequencing of the whole transcriptome. And then in terms of some background in the literature, so, we know that PSMA PET is more sensitive and specific compared to traditional imaging, such as MRI. And there is some controversy about this, but there are some studies that have shown that PSMA expression correlates with disease aggressiveness. And there are other studies that have shown that there may be some relationship between Decipher scores and probability of having PSMA avid lymph nodes on imaging. But overall, there's not a lot in the literature about the SUV max and that value and what that value actually means clinically and how we can use that to sort of better understand a patient's risk level or what things might look like for them in the future. Thus, the aims of my study were to understand the relationship between the SUV max of the primary tumor on PSMA PET and clinical pathologic and genomic factors in patients with prostate cancer. We focused on the patients in the initial staging setting, and then in particular focused on patients who were undergoing radical prostatectomy. And that was, partially, of course, my primary interest, is in the surgical patients, but also these are the patients that we have pathology on. And so we have that gold standard kind of measurement to look at their pathology, and ultimately trying to answer the question of the clinical utility of the SUV max. So in terms of our research design, this was a retrospective review. We looked at all of the scans that were done from when we first started doing PSMA here, which was in 2015, up until the very start of my research year in July 2022. And we identified 3,600 roughly scans that were done in that time. We identified those that were done in the initial staging setting and included those for analysis. And all of the demographic, clinical, genomic factors were gathered from the medical record. And then we used the DICOM software called Visage to measure and record the SUV max for all of these scans. And in doing this for 591 scans, I fulfilled my goal of becoming part radiologist for the year. So it's not that complicated. Basically, you use a region of interest tool to encircle the prostate and record the maximum SUV value within that region of interest. And you have to take care that you don't get the bladder or the ureters in that measurement as the radionuclide is excreted in the urinary system. So our variables are sort of as expected: age, PSA, Gleason grade, T-stage, SUV max, and Decipher. We broke up the SUV max into quartiles for a lot of our analysis. And the outcomes that we looked at were primarily pathologic factors at radical prostatectomy. So maximum Gleason score, ECE, SVI, presence of positive lymph nodes. So in terms of our results, so we had 591 scans that were identified as having been done in the initial staging setting. 218 patients went on to have a prostatectomy, and of those, 194 had lymph node dissection at the time. The other, like 400 patients, 200 or so went on to radiation, and the other 200 or so were metastatic at diagnosis and so went on to systemic therapy. So around 40 patients had PSMA positive pelvic lymph nodes prior to RP, and then similar number had positive lymph nodes at RP on pathology. We had 165 patients who had Decipher testing, which was a combination of biopsy and prostatectomy specimen. So in terms of our table one, I have in one column the whole cohort and then the RP cohort as well, just so you can see how the RP cohort kind of compares to the overall group of patients that had PSMA at initial staging. Overall, they're very, very similar in terms of all of the factors. You can see that for both groups, the mean age was in the late 60s. The vast majority of patients were white. Median PSA at diagnosis was around 10 for both, and then the majority of patients were in the NCCN high risk group or above, which makes sense with the types of patients that were tending to get these scans on. The T-stage was sort of across the board, although tended to be in the higher stages, similar with the highest Gleason score. The majority of patients were in 4+3 or above. And the median Decipher score was 0.7. So all of this together, this is overall a higher risk group of patients, which again kind of tracks with who we're getting these scans on. The median SUV max of the primary tumor was around 14, both for overall and for the RP cohort. And there was quite a range of SUV values, as you can see, ranging from sort of barely measurable all the way up to 132 for the whole cohort or 73 for the radical prostatectomy cohort. So in terms of our results, and actually before I get to that, I'll go back and say, in going back to sort of the initial question about sort of the clinical utility of the SUV max, I think, we see these values, or you see the value of 73 or of 40 or whatever it is, and you see it on the report. And at least when I see that, I think, oh, that's sort of a high number. That must mean that, that this is an aggressive disease, or that, things may look different for this patient in the future. But that's sort of what we were trying to answer with these, finding out what these numbers actually mean. So in terms of our results, so one of the primary things that we wanted to look at was how SUV max relates to these various pathologic outcomes at radical prostatectomy, and we found no association between the SUV max and any of the outcomes that we looked at. So I think this looks a little bit nicer in the table. So you can see our p-values, and there were no significant findings in any of these comparisons between SUV max and all of these different things: T stage, ECE, SVI, positive margins, and all of these factors. One thing that I think was really interesting that we found in our study was, overall specificity across the board, regardless of what quartile you're in for SUV max, was excellent, which is as expected and consistent with the literature. The sensitivity, though, for, and this is for lymph node positivity at prostatectomy, increased really nicely as the quartile of SUV increased. And so I think that was a very interesting finding and something that could be very clinically useful. This finding wasn't statistically significant, and you can see we overall have very low numbers of patients within each quartile, and overall very low numbers of patients with positive nodes. And so we may have not had the power to sort of detect a statistically significant finding, but overall I think this trend of increasing sensitivity with increasing SUV quartile is interesting and clinically important. And so this is essentially the same thing, just shown in graph form. So specificity and negative predictive value was excellent across the board, as we expect. And then sensitivity increased nicely with increasing of the SUV quartile. And then in terms of how SUV max relates to Decipher, we essentially found almost no relationship. This is for the whole cohort at initial staging. So this is for the 600 patients. And this is a mix of biopsy and RP Decipher specimens, but you can see that there's essentially no or only a very weakly positive relationship between the SUV max and the Decipher score, with a correlation coefficient of only 0.2. And then this is essentially just a nice sort of confirmation finding within our own data. So like I mentioned before, FOLH1 is the gene that encodes PSMA, and this is there's a value to the amount of expression that we get as part of the Decipher data. And so we took our own patients' data and compared that to the SUV quartile. And as expected, as SUV quartile increases, the expression of PSMA increases. And so this is very expected, but I think it was just a really nice finding to see within our own data to kind of have that confirmation. So overall, like I said, there was excellent specificity for the PSMA scans for lymph node positivity at RP, and there was increasing sensitivity with increasing SUV quartile, which I think, although we did not have statistical significance for that, I do think that's a clinically significant finding, and that at some point in the future we may have sort of an SUV value that helps us determine who needs lymph node dissection at RP and who doesn't. I think that's in the future, but I think that could be something really interesting that could come out of all of the SUV work. The FOLH1 expression increased with increasing SUV quartile as expected, and then there was no relationship between the SUV max and sort of all of the pathologic outcomes at RP, which I think kind of indicates a limitation in that regard in terms of risk stratification or evaluating sort of the aggressiveness of the disease. So also want to give a huge shout out to all of my mentors and collaborators. This project was a huge team effort, and I definitely could not have gotten any of it done without all of the people on this list. And shout out to Kevin, who just presented our work at the AUA this past weekend, and sounds like it was really well received. And also want to give a big thank you to the T32 program. I think I was the first non-radiology person to ever do the program, so I think it hopefully opens the door to others who are interested. And like I said, it was an amazing experience, and the mentorship that I got from from Dr. Hope in particular was incredible, and all of the opportunities I had to take coursework and sort of actually learn how to do research was really amazing. Yeah, the end.
Last but certainly not least, we're going to hear from Dr. Mary Fakunle. I think these chief residents actually demonstrate the breadth of the research year here. And so, Mary went into the basic science lab, which is a really awesome opportunity that is hard to come by when you're in a urology residency, because you really do need a, significant chunk of time to be able to make progress in the lab. And she had an interest in healthcare disparities and really was able to do that in the lab in partnership with Dr. Huang. So we're very proud of Mary, who is going to graduate this year and go on to do a fellowship in oncology at UCLA. Mary, we look forward to hearing about your research here.
Thank you, Dr. Hampson. Okay, so my talk is called Finding the Missing Gene, which is a part of the RESPOND study, which I'll talk about what that means. No disclosures, and any of the data that I present is unpublished, so don't post it. So when I think about my goals for the research year, it really sort of stemmed from, these things. I knew I wanted to go into oncology and do an SUO fellowship. Very interested in prostate cancer in general, had done some clinical prostate cancer research in Dr. Carroll's lab, have always been interested in health disparities, even, before going into med school is what I talked about consistently. And then I think I was kind of deciding whether I wanted to do clinical, translational, basic science. And I had done a little basic science in undergrad, and I kind of like the idea of being busy, going in every day, working with my hands, hence wanting to be a surgeon. So I did not shy away from the idea of doing basic science for my research year. With all those things I was interested in, I was fortunate to find Dr. Franklin Huang and be a part of his lab. He is a medical oncologist here, and he also works out of the VA and has a basic science lab. And I think, this was sort of a quote from his lab website and what they focus on. So experimental computational approaches to understand how cancer develops and find new ways to diagnose, treat cancer with a focus on underrepresented populations. Could not be more perfect. So he introduced me to the RESPOND study, which his lab is a part of, with a focus on genomics of prostate cancer disparities. So what is the RESPOND study? This is kind of a snapshot from their website. The RESPOND study is research on prostate cancer in men of African ancestry, defining the roles of genetics, tumor markers, and social stress. So that's exactly what it is. It is a project that involves a bunch of institutions across the country, and each of them sort of providing a different aspect of this study. And so what it involves is there are over 10,000 African-American men enrolled. Enrollment comes from California, Texas, Louisiana, Georgia, and New Jersey. And it's evaluating germline, somatic, and survey data to determine what gives rise to aggressive cancer in African-American men. So the survey part is really looking at the social determinants of health. So it's asking questions about family, health history, neighborhood, all these things that we know that contribute. The patients also had saliva samples and prostate tissue collected, and that allows us to address the lack of African-American samples within prostate cancer cohorts. In Franklin's lab, we actually had access to the whole exome sequencing data, and this was tissue from both the malignant and non-malignant tissue from the prostate. And we were evaluating the data for somatic mutations in the prostate cancer tissue, looking for patterns of recurrent mutations. So just talking a little bit about what I did when I showed up, I had a little bit of wet lab work and sort of dry lab work, so to speak. And so there was a massive sort of map file, Excel file that had every single mutation from every patient that we had in the study. And at that point, I think it was about 120 African-American men with high-risk prostate cancer. So every single mutation that was found within the prostate tissue. And Franklin said, okay, find the mutation. So I sort of combed through this giant file and just sort of looked to see if there were any sort of mutations that were recurrent, how often they were recurrent. And then from there, I compared it to cohorts that already exist, like TCGA. And TCGA just has banked cancer tissue, all types of cancer, and just looks for, looks at the genomics of the tissue. But the issue with that is predominantly European American. So a lot of the information that we get from it isn't transferable to all the populations that are dealing with prostate cancer. So what I did was I used the list that I had and just sort of compared frequency of mutations or presence of mutations to see if there was a difference. The data that I had from the RESPOND cohort, it looked at everything, the mutations that were available, the allele changes that were within the population, also tumor allele frequency, which would give us an idea of whether it was likely artifact or likely real. These are some of the resources that I use. So NOMAD basically allows us to assess if a single nucleotide variant is present within the normal population and how frequent it's present. The Cosmic CBI portal allows us to compare mutations that are found within other cohorts like TCGA. And then I just did a lot of literature review to see if the specific gene has been mentioned in prostate cancer or other cancers, or whether that specific mutation was mentioned previously. So this is kind of a snapshot of my working Excel sheet and just all of the things that I was looking at within the massive Excel file I had, and then just kind of combing through the literature. In the top right are commonly known prostate cancer genes and the frequency within our cohort versus TCGA. So just trying to get an idea of how this population compares to a commonly used TCGA cohort. The other thing that happened when I showed up is that Franklin already had a mutation in mind. So, RPL10 is the gene that was going to be the focus of my research year. And the mutation that was found within our cohort was the R210W. It's a missense mutation. At that point, it was in 4.4% of the RESPOND cohort versus 0.2%. And TCGA and the allele frequency was 33 to 86%. So it looked like it was potentially a real mutation. Within Cosmic, the R210W was identified in pediatric brain cancers, interestingly enough. There was an RPL10 missense mutation found in a total of 127 samples, including lymphoid, endometrium, breast, and skin samples. And one was found within prostate, but it was not the same mutation. And this allele variance was not found within the normal population. So this is just sort of a snapshot of the actual R210W and the fact that it's been found in various pediatric brain cancers and has been banked within that cancer tissue. A little bit about RPL10. It is a ribosomal protein, L10. It encodes that protein, and it's located on the X chromosome. It's a part of the 60S subunit, and it's involved in later steps of the subunit assembly. And the 60 and 40S subunits catalyze proteins within the cell. The translation product of the gene is highly conserved from yeast to humans, so it is an important gene. And so the question that we're asking, or that I was asking at the beginning of the year, is whether this recurrent mutation is real and relevant to high-risk prostate cancer in African-American men, which is obviously a very heavy lift for just a year, but that was sort of the starting question. I think the other sort of hypothesis was assuming that it is real and relevant, our thought is that it would cause some sort of change in behavior in the cells. And so that's really what I was able to focus on for the year. So this is an overview of the experiments that I did. Very sort of broadly started with a plasmid that had the gene, making the mutation in the lab, making a virus that I could then use on the cells, using various cell lines, Western blot to show that the cells are expressing the protein, and then a various number of growth assays to see if it would change the growth compared to the wild type. So some of the cell lines I use, all of them are prostate cell lines. The first two are prostate epithelial cells. The second two are metastatic prostate cancer cell lines. And then the last one, MDPCA2B, is metastatic prostate cancer cell line from an African-American patient. So that one, of course, was a little bit more relevant to our context. So again, ordered the RPL10 plasmid, made virus so that I could use it for various experiments. I did a quick change synthesis to actually make the mutation. That took a lot of time. I did my lentiviral transfection and then collected the virus. And so I had the wild type virus as well as the mutated RPL10 virus. And then this is just a picture of the actual, we did Sanger sequencing to confirm that I had made the change, which was very exciting. So the first thing we focused on were the Western blots, to prove that the protein is actually being expressed in the cells. Used a V5 antibody because that was the tag on the plasmid. Also use antiviculin just to show that the cell is making protein, so kind of a control. And then also use the RPL10 antibody just to show that the cell is already expressing RPL10. So I'm just going to kind of fly through some of the Western blots because they're Western blots. And this is the first one. I'm going to highlight that this beautiful Western blot was not done by me. It was done by Kellyanna, who's one of the lab members. And it's just so beautiful. I had to include it. And now these are all my Western blots. And so just showing that different cell lines at different passages are expressing both the wild type and the mutated RPL10. So that's shown on the right side, and then on the left side is just the endogenous RPL10 that's being expressed. So this is our PNT2 cell, same thing, and then our MDPCA2Bs, and then this is one of my proudest Western blots because I'm showing that the MDPCA2Bs are kind of equally showing expression of the wild type and the mutant. So one of the conclusions is that, again, I was able to show expression of both proteins and most of the cell lines that I used. One pattern was that the expression of the mutant RPL10 was always a little less than the wild type, even when the protein levels were equal. So one question that came out of that was whether our V tag was a little too close to where the mutation was, and maybe that was altering the way that the antibody was able to attach. Sorry. So just an example of kind of doing the work over and over and over again, and then saying, maybe that wasn't, maybe that's something that we needed to fix. So basic science. So these are some of the growth assays I did, and just showing just so many that I did. And this is only a few of them. So one of them was the cell titer glow. This is a luminescent cell viability assay. It's a short growth assay. So it's really just 4-day period, starting with an equal number of cells, and just seeing after the 4 days what the difference in the cell viability is. And we did after 4 days, and we actually did it for each day to see how the growth changed over each day. And it just measures growth activity, and the goal was to use the cells that we know are expressing the protein based on the Western blot. So these are just some of the results. I would say, this is a lovely example of what in our heads we would like the results to look like. The mutated RPL10 is showing the greatest growth pattern after the 4 days, and it's so beautiful. But then you get results like this. And so everything is just kind of all over the place and not as consistent, and it makes you wonder kind of what exactly is going on. This is one of the 4-day where we collected each day with our MDPCA2Bs, and you see that obviously all the cells are increasing their growth with each day, but it looks like there's not too much of a difference between our wild type and our mutant. And so the next sort of growth assay that I did is focus forming assay. It's a longer growth assay with immunostaining to quantify growth ability. Different number of cells were plated with replicates of 3, and the growth time was really just based on the cell type. When the growth was stopped, we stained the cells with crystal violet and imaged. Then the stain was dissolved with acetic acid, and then we measured with an optical density reader, just again to measure the growth. So this is with our PNT2s, a nice sort of picture of the growth after it was stopped, and then again measuring sort of the growth with our optical density, with the Ellen cap, another prostate cancer cell line, with our MDPCA2Bs. And so again, not always the results that we're hoping for based on our hypothesis, but just sort of some of the results that we got. So I would say the conclusion from those 2 growth assays, it seems that the mutated RPL10 is growing faster than a wild type, although it's not always significant. Our luciferase, which was our control, the growth was pretty inconsistent. So it was very hard to interpret the results when your wild type, or when your control is not being consistent. And the discrepancy was possibly due to a non-standardized protocol. a small quantity of the cells per well, numerous things that we kind of thought about as to why the results weren't always consistent, but again, basic science. So one thing that was noticeable about our MDPCA2Bs, which again are the metastatic prostate cancer cells from the African-American patient, the cells tended to be able to grow and be viable without needing to be attached. And so obviously when doing these assays, you're washing and you're kind of, you know, removing the wash or the media. And so a lot of the cells are actually being washed away that don't get included in these growth assays. So that was particularly true for our FFA. And we would find that there were almost no cells in our mutated sort of wells because they were all being washed away. So then we decided to do a low attachment growth assay where we could actually see if the cells would remain viable in a plate that didn't allow them to attach. So that was one of the final sort of experiments that I did towards the end of the year. And it seemed like it was going in the right direction with our hypothesis, the fact that these cells weren't attaching, but they're still viable. So this is one of the results that I got that I was pretty excited about and kind of left wanting to do more, but, you know, ran out of time. So that's an overview of kind of how the year went. Other potential assays that we talked about was repeating the low attachment growth assays, short-term versus long-term, using CRISPR to actually create the mutation within the cells. So obviously with my experiment, I'm adding a plasmid, which is adding another copy of the RPL10 gene. And so that's another sort of confounding thing. We don't really know what effect that has. So we started using CRISPR to actually change the endogenous RPL10 to make the mutation that we wanted. Using RNA sequence, ribose sequencing to get a snapshot of what this protein is interacting with, and then immunoprecipitation as well to see how it's interacting with other proteins within a cell. So to wrap up, lots of lessons from the year. The first and biggest one, Rome wasn't built in a day. Prostate cancer can't be cured in a year. So, you know, it's a ton of trial and error. And I would say learning about myself, I never really got too frustrated when things didn't work out. It was always, all right, what did I do wrong? Which calculation was wrong? Oh, that was really wrong, you know, and trying to just fix it. And then when things work out, it's extremely gratifying. And then learning to ask the right questions. So Franklin was really, really patient with me and very helpful in sitting down and figuring out what we should be asking and what we should be fixing about the assay and what we should be focusing on next. So just some of the lessons. And then I also learned that I really like basic science. So I think this is something that I will want to continue, whether I'm doing it or collaborating with someone who does it. I think it's very rewarding, and there's a lot that we need to sort of be focusing on. I want to thank the members of the lab. These are just some of the members that were so patient with me. You know, you feel smart and then you go into a basic science lab and you realize that you're not really that smart. So, you know, I had these undergrad students that are just really breaking it down for me, and I appreciate it. And these are some of the pictures from our outings. Lab members like to go out and have fun. You know, we'd go bowling and mini golfing. So that was cool. And obviously I want to thank Dr. Franklin Huang for being very, very patient with me as well. And that's it.
Thank you for those amazing presentations. And, you know, I really do think that oftentimes people don't know their interest in research until they're given the opportunity for it. And we've seen so many trainees that might have thought that they, you know, wouldn't take an academic path. And then whether they're a medical student or a resident or during their research year, they have the opportunity to dive into research. It really changes their trajectory. And that's why we're here. Is to kind of stimulate that interest and give people those opportunities. And we're really hoping to continue, you know, our research as we move forward, and are looking for our Hinman Society to kind of create a culture of togethership, of sponsorship, of community, and hope that as we move forward, we can draw on all the experts that are both here and alumni to support our research mission. So thanks so much for listening. And I'd love to take some time to ask some questions for any of our chief residents. And maybe what we'll do is when people ask a question, I'll try to repeat it for the video, and then I'll have the chief resident come up. And
yeah, just a comment. The chief, very proud of you. Presentations, I thought were solid, great work. I also want to thank the faculty. It's a big expense to have a research year. We actually recently, 2 years ago, surveyed the faculty. Like 95% of the faculty. It's incredibly important that we are a research department and central to our identity. I also want to thank Lindsay, who led the R5 committee, and now Anne, who leads the R5 committee, and all of the faculty, Annabelle, Howe, Nita, David.
That's everyone.
I want to thank them because it's I think, diligence and the quality that's coming out of that research amplified by all people that start thinking about these things. That's
yeah. Just to echo for the video, I'll just say, yeah, huge thanks to faculty who mentor and support and participate in the R5 committee. I know it is a lot of work, but I think we've gotten shown just amazing results from our chief residents. And yeah, so proud of each of you. Any questions? Carissa? Here, Dom, can you come and just repeat briefly the question?
Yeah, the question was for patients who had lymph node negative disease at RP or on PSMA. At RP, whether they had low FOLH1 expression. We have not looked at that yet, but that would be something. Yeah, and one of Tom Hope's interests in particular is like PSMA cold tumors, like prostate tumors that don't express PSMA. So I think that could be really interesting to look at too.
I just want to make a plug for the YouTube TL1 grant. We have funded for that 25 years. So I think anybody got that, understand that opportunity for all of you departments. Bring that on. If you have any questions, T32s are being eliminated.
And the U2TL1 program really has a lot of dedicated mentorship, sponsorship, learning about grant writing, learning about research methods. So there's a ton that goes into it apart from just funding support. And I think, we've all seen the benefits of having really dedicated mentorship and a pathway that's really laid out to support research careers. John.
Yes. Yes. So Dr. Lindsay asked about for the MDPCA2Bs that had the mutated RPL10, they seem to do well on the low attachment assay. And if that has implications. Thank you. Implications for metastatic disease. Yeah, I mean, those cells are already metastatic cells. They are already coming from an African-American patient. So I think it was even more interesting to see that potentially this mutation was making them their ability to remain viable unattached compared to the wild type, improved. But obviously everything in basic science has to be replicated and verified. So it was a cool finding to have. I don't know if we can have any real takeaways from it, but it was, interesting for our hypothesis. Mm-hmm. Yeah. Yeah, I mean, so for our other studies, like you mentioned, where they have normal attachment, we are selecting for the ones that have the ability to attach with so the assumption that the ones being washed away have something wrong with them. The study that we did, the low attachment, we're still measuring their viability with the luminescence. So we can't really say how abnormal they are, but they are still making ATP. They're still functioning as cells even in that state. So that's why we did that, the low attachment assay.
All right, so just to wrap it up, I want to say again just how proud we are of these chief residents, and we'll get to celebrate them, next month during graduation. Just makes me emotional just thinking about the fact that that's coming so soon. But I do really want to just end by making a plug for research and how people can incorporate it into their careers in different and unique ways, and make it your own. Thank you so much to the mentors who supported these residents during their research year. And I think we are particularly lucky to have amazing partnerships with people outside of our department. And that's something that's truly special and unique, to have people like Franklin Huang and Tom Hope, who are dedicating a lot of their time and energy to our residents, to making them better and to cultivating their research passion. So thanks to all of the mentors who really have supported research for our trainees. And thanks for listening. Don't forget to do your CME.
That's